Uh, at the outset, while I shared my presentation, I'd like to thank Dr. Gujral and Dr. Borges, ma'am, to give me this opportunity. Thank you to my co-host, Dr. Vatsla and Dr. Sindhura, and all the lovely students for volunteering to participate today. Uh, so today we are going to discuss two parts. Approach to thrombocytopenia will be a little bit of clinical orientation of thrombocytopenia. I have already shared a reference article from which I have used for my presentation. A few of you must have gone through it. And basically the discussion is going to go to day-to-day practical tips and troubleshooting for platelet counts in clinical practice or lab practice. So the focus will be more pathology-based. Initial few slides will be clinical approach. Now, before I jump to approach to thrombocytopenia, it is good to understand what is normal thrombopoiesis or platelet development. Liver plays a very important role. Like we know, erythropoietin comes from kidney. Thrombopoietin is constitutively secreted by the liver. This thrombopoietin binds and is catabolized by the CMPL receptors. So this MPL receptor is present both on the platelet and megakaryocyte. So the TPO level in blood is proportionate to the mass of the MPL receptor. So you have to keep in mind the balance is between platelets in the peripheral blood and megakaryocytes in the bone marrow. In a patient who has increased platelets, the mass in the peripheral blood is more mass of MPL receptors. So there is less thrombopoietin available to go and stimulate megakaryocytes in the marrow. So there is decreased thrombopoiesis. However, if there is decreased platelets, the mass of MPL receptors in the blood is low. That means there is more thrombopoietin available to go to the marrow, which stimulates megakaryocytes, and there is thrombopoiesis. So in a normal cycle, there is an inverse relationship happening between the two. More platelets, less TPO available, so less thrombopoiesis because the body does not require it. And less platelet means peripheral blood requires more platelets now, and hence the marrow is being stimulated to produce more platelets because of this thrombopoietin being available. However, we also know, like in an infection inflammatory reaction, for example, IL-6 is a very important interleukin, which is also known, in addition to the constitutive secretion of thrombopoietin by the liver, it will increase thrombopoietin production because of inflammation. This leads to reactive thrombocytosis. Vice versa, if you have liver failure, like in cirrhosis of liver, there is going to be a less constitutive secretion of thrombopoietin. So many liver failure patients or cirrhotic patients have a mild to moderate thrombocytopenia because of lack of thrombopoietin production. So TPO is very important because one of the target molecules which is used for treatment of thrombocytopenia like romiplostin or other drugs are also thrombopoietin analogs or mimics of thrombopoietin, which help to stimulate the marrow to produce more platelets. So this is in brief the basic physiology of platelet production and regulation in the human body. Before I jump to approach to thrombocytopenia, I stress again, this is the CBC photograph from one of our analyzers. Not only this is a normal sample in a 25-year-old male. When we see normal, we get these colors in your instrument, which is green, means everything is normal. There is no flag, normal histogram, normal everything. Please focus on the units. I had discussed this in the previous talk of CBC. And here, platelet, the unit given here is 205 into 10⁻³ per microliter. Okay, so units are very important, and normal range is very important for any parameter. So normal range for platelets, as you know, is 1.5 lakhs or 1,50,000 or 150 into 10⁻³. I'm purposely stating different ways of stating the same platelet count. The other way would also be 150 into 10⁹ per liter, because you will come across verbal reports, handwritten reports, typed reports, international or Indian reports with different units. So it's important for you to identify these are all similar units and know their conversion and interpretation. Okay, so normal range is 1,50,000 to 4,50,000. If you were to do a study where you were to take all males separate and all females separate, though the normal platelet count range is said to be common for both, in actuality, the median normal platelet count for females may be slightly more than males. This is physiological and this is well documented. Again, it may be of no clinical significance in a given scenario or a given case. So current definition of thrombocytopenia typically means platelet count of less than 1,50,000 or less than 150 into 10⁻³ per microliter. Okay. Now, one of the students is going to answer this first question. I have made pairs So this is, you have to identify which is the wrong pair over here, and if there is any wrong pair, and which is the wrong unit and why. So can one of the students been assigned this question share with me which they think is the wrong pair?
I have assigned for this
Please
question.
go ahead. Yes.
And sir, the second one is wrong here.
Okay. Can you identify what is the mistake?
Sir, it should be 135 multiplied by 10 to the power 3 per microliter.
Excellent. So I will repeat for the use. You are perfect. The answer is correct, Divya. So first one is 55 into 10 raised to 3. It is nothing but you add 3 zeros, so it is 55,000 per microliter. This is conversion between microliter to liter. So 1 liter is 10 raised to 6 microliters. If this is 10 raised to 3, the difference between year and year should have been 6 zeros. So it should have gone from 10 raised to 9 to 10 raised to 3 per microliter. So you are perfect. So everywhere when we write liters for platelet, it's 10 raised to 9. For RBCs, it will be different. It will be 10 to 12 per liter. So the units are different for WBCs, for platelets, and for RBCs. Again, some people might write 1.25 lakhs, or they might write 125 to 10 to 3, or they might write 1,25,000. It is the same. Okay. But you need to know, is it per microliter? Is it per liter? Okay. Same here. 25 to 10 to 9 per liter, or traditional way on Newbar chamber you should say per cubic millimeter, which is the same as microliter. So it is 25,000 per microliter, or 25 into 10 is to 3 per microliter, or 25,000 per cubic millimeter. Currently, in most current day analyzers, the unit which you will see will be this one, 55 into 10 is to 3 per microliter, or 125 into 10 is to 3 per microliter. This is the essence of showing you the importance of using units, because if you write a wrong unit, the clinical interpretation may be totally different. This is important because we are aware thrombocytopenia is very, very important. Urgent reports are given over the phone, over WhatsApp, over images. Typing mistakes happen, and this should not happen. So this is an article by Roberto Stacey, which is ASH education article, which I have used and also shared with you. We'll be using this as an approach to clinical approach to thrombocytopenia. A little theory slides for the next few slides. So most important different causes of thrombocytopenia is what is listed here. Pseudothrombocytopenia means false cause. It's not truly a thrombocytopenia. Then you either have increased destruction of platelets in the periphery, either immune or non-immune, or the marrow, which is the factory where blood is produced, there is decreased production, which could be primary, like a marrow failure or a aplastic anemia. Secondary, because of infiltration, metastasis, a leukemia developing or something like that. Dilutional thrombocytopenia means, for example, in pregnancy, when you have a high volume or for some other issues, there's a dilutional thrombocytopenia. And then increased sequestration, which is very close to peripheral destruction, or in a case of hyperspinism, you might see increased sequestration. So the causes of thrombocytopenia are different. Physiology and pathology is different. If you approach the clinical scenarios, there I was telling you the physiology or the pathophysiology. If one approaches clinical scenario based approach to thrombocytopenia, you could tackle it from an outpatient point of view, an OPD patient who's otherwise doing well, or an inpatient point of view. And this is important from a clinician's perspective, and we as pathologists should know this very well. Typically, immune thrombocytopenia, which is ITP or drug-caused immune, then infections are very common. Various viral infections. Especially, this is being non-Asian or non-Indian article. You will not find things like malaria, dengue in this list, but we know we face a lot of our viral infections commonly. These are rare ones, but we also see in practice like HIV, hepatitis C, CMV, and various other viral infections. Connective tissue disorders, post-vaccination, we all know post-COVID, we have seen many cases. Then you have outpatients, especially elderly, you may have a low-grade MDS, rare causes like congenital thrombocytopenia or immunodeficiency. Typically in a ICU patient or a cardiac patient, the causes are different. They may vary from infections, TTP, HUS, and I'm not going to the whole list. Whereas cardiac patients, you should remember heparin-induced thrombocytopenia, cardiac bypass, drugs. Pregnancy is a whole list, which might discuss in a separate slide. So if you know pathophysiological causes, sort of a clinical approach, inpatient, outpatient approach, the other important approach is to take the history of the patient. This becomes very, very useful. Is it acute or chronic? Is there a skin or mucosal bleed? Is the patient having menorrhagia? Is this a massive GI bleed? Is there an intracranial bleed? These are different conditions associated with thrombocytopenia. You will find these kind of causes. Are there any associated illnesses? Is the thrombocytopenia the patient being completely normal, or is it associated with the fever? Is there organomegaly or lymphadenopathy? That comes from clinical examination. Drug history is very, very important. Sometimes we miss this. Uh, Allopathic may be mentioned or told to you. Non-allopathic patients might feel this is not important. They might be taking a Chyawanprash or a supplement or a Kada, or we don't know what they are taking. But these are important because we don't know what all combinations this patient is taking. Now, family history of thrombocytopenia. Is there any association with any disorders? So, genetic history. Heparin exposure, especially as I said, cardiac patients, ICU patients, this becomes important. As I mentioned, your liver disease, cirrhosis, lack of thrombopoietin production. And then, does the patient have any risk factors for sexually transmitted diseases or viral infections like HIV, HCV? A patient who's immunosuppressed, are there any other causes one needs to look at? So, these are clinical ways one can approach. And I'm not going to go into the details of it, but broadly, you start thrombocytopenia, first thing, double check your CBC, double check your smear, rule out if it is artificial thrombocytopenia or true. If it is true, these two causes over here, cystocytes or spherocytes, means there's RBC abnormality, so the approach becomes different. Are there WBC abnormalities? Are there blast, nucleated RBCs, dyspoiesis? You might require a bone marrow. If there is atypical or activated lymphocytes, viral infections, is there a lymphoma there? Are there abnormal cells? Are you looking at infection versus absolute lymphocytosis? Your infective workup will include ESR, CRP, chest X-ray, viral PCR, blood cultures, etc. If there are no RBC, WBC abnormalities, no fever, are you looking at an isolated thrombocytopenia? Is it immune? Is there a drug history? Are there other viral infections? Is there heparin exposure? So again, you need to go back onto your clinical assessment. So it is a combination of features, but if you go back, everything comes back to the peripheral blood smear, clinical history, and the clinical assessment. So that is the first two slides I showed you. The clinical assessment, the history, and a very good peripheral smear with the pathologist is the most important. Now, pregnancy being specific, I have just labeled two slides. In pregnancy, you can have pregnancy-specific causes of thrombocytopenia and non-pregnancy specific. Means whatever happens in a non-pregnant person can also happen to a pregnant person. So those are non-pregnancy specific. We'll come to that. But in pregnancy, gestational thrombocytopenia is the most common etiology and happens in 80%. Very often, second or third trimester digestional thrombocytopenia may be the cause. Preeclampsia, very important cause. A complication is HELLP syndrome, which is nothing but hemolysis, elevated liver enzymes, and low platelets. This is important to recognize. So, in a pregnant patient with thrombocytopenia, look for hemolysis, look for liver enzymes, look for liver function test, and then there is acute fatty liver of pregnancy. The other non-pregnancy specific causes can be any other cause which we had discussed earlier. So with that, my theoretical approach to thrombocytopenia was short and specific. And I'm going to stop there and we are going to go to platelet counts in a laboratory. That's what our focus of our talk is going to be today. It's going to be more on basic counting, the basic histogram, and basic peripheral smear approach. I am not going to go into the various platelet parameters like PDW, MPV, and those can be a different discussion altogether. Let's stick to the basics today. So the next student is going to answer this question to me. What is the current gold standard methodology for platelet counting? So who's going to give me the answer for this?
This question was assigned to me, sir.
Yes.
The current gold standard methodology for platelet counting is flow cytometric RBC platelet ratio, sir.
Excellent. So we'll try and go through all the four methods today in our talk. The Newbar chamber, the impedance-based platelet counting, optical platelet counting, and the flow cytometric ratio. So it is important to know the historical perspective. Platelets first recognized in 1882 by the Italian pathologist, Giulio Zero. 1953 is when Newbar chamber was introduced. And if you go on, you will notice that this remained the gold standard from 1988 to 2001. And when we say gold standard by the International Council for Standardization in Hematology, this was the methodology used for when any company wanted to validate their instrument and platelet count. They had to compare the platelet count with the Newbar chamber. Then the era of automation started. We had semi-automated and fully automated. You had the impedance counter in 1981. Optical technology came in 1985. Then you had flow-based methods in 1990. It was only 2001 when the gold standard was changed to flow cytometric RBC platelet ratio, which is also known as the international reference method for platelet counting. So every one of you, I'm sure, has seen Newbar chamber and used it. As you all know, it is a little laborious. It is time intensive. You have to load the sample, you have to wash the chamber afterwards. There is a lot of subjectivity involved. And you would have noticed that if you are having very low platelets or very high platelets, the variation between two observers, and sometimes within the same observer seeing two samples, is as high as 10 to 25%, which at clinical levels can become very challenging. So this is the article where they first published the international platelet reference method. Basically, what they do is they use a fluorescent antibody like 4161, which is a marker present on platelets, an antigen which is nothing but GP2B3A. So this is the antibodies to GP2B3A. They mark the platelets. So they are here on the top left axis. RBCs are negative based on size. They are gated on the right axis. So what we do in this is we take the platelet events from this box, RBC events from this box, and we multiply it by the RBC count, which is obtained from the automated RBC analyzer, because that is supposed to be a very, very accurate count. RBCs are in millions over there. So this ratio of platelet events to RBC events by flow is what is utilized for calculating the platelet count. This is something that is very close to my heart. This was my first international publication at first name publication at Tata Hospital, where we did something similar. We did the CD4161 based flow cytometric platelet count, and we compared the platelet count on two analyzers. One of those, the Beckman-Coulter one was Abbott counter, and also with the RIA matrix method. So essentially, we did a comparison and verification in our laboratory between different technologies in different instruments based on the flow-based platelet count. Now, if you noted, in all the method which I mentioned, there was no mention of peripheral smear platelet count. I've asked all of you, how does everyone do manual platelet count? And I've asked this to many students. Everyone says I'd use the peripheral smear. Nowhere in the method is peripheral smear mentioned as an accurate method of platelet counting. So I label it either as a peripheral smear platelet estimate, where it's only truly an estimate, it's not truly a count, or a platelet check. And the reason of calling it the check, in most scenarios, 99.9%, it is just checking whether the counter which is giving you an accurate count. And we'll discuss this as we go ahead today. Challenges which we face, obviously everyone knows platelet clumps, syncretism around WBCs, smearing, and as we go ahead, you'll realize it's highly subjective. Now, even if you do a peripheral smear platelet check, it is important to identify which area of the peripheral smear. In a tongue-shaped field, it is not the edge of the tail, neither the deep in the body. It is the zone of morphology where RBCs are well separated. So not in the tail where there is this aggregation of RBCs, not in the body where there is overlap of RBCs. You need to do it where RBCs are individually separated. So this question is to the next student.
So I have been assigned this question.
Yes. So if you can tell me, this is a single field of view under a 100x objective, and I have told this is the reference field of vision for counting after seeing. This is the best field I could share with you. On a big microscope, latest one with the field of vision being 21 millimeters.
So although the average of 10 fields is taken, so based on this field, the peripheral count platelet estimate will be 1,60,000. So there are 16 platelets on this field.
So you did a multiplication factor of 10,000.
10,000.
Can you tell me why did I give you this field of vision 21 mm? And if I told you
So the area of vision, the field of vision, it is 21 millimeter. So that is the field number. So the diameter of the eyepiece will depend on the eyepiece will depend on that. So and the area will change according to that. So if the area is higher, then we need a smaller multiplication factor.
So the importance more than the multiplication factor is that you're right, that if you have an older microscope with a field of vision of 18 mm,
18 years,
so you will see less platelets. Yeah, you will see less platelets. If you have a bigger field of vision, you'll see 21 millimeters. Nowadays, you have these microscopes where they have attached the iPads or the digital screens. Okay, and depending upon the connector they put, the field of vision which you see under the eyepiece and the field of vision which you see on the camera or on your phone or on your screen is totally different. So you should be aware that the field of vision is different, and hence we always recommend that based on your microscope, your camera, your counter, one can analyze it, one can find out what is the multiplication factor you need to use. So typically, first thing is count at least 10 oil immersion fields in a close to normal platelet count. When you have very high platelet count or very low platelet count, you might count up to 20 fields and take an average. With current day microscopes with field of vision of 21, in my personal experience and analysis, we use the multiplication of factor 10,000. I'm aware certain textbooks give a factor of 15,000, certain references, older ones will give you a reference of 20,000. It's best that you in your system, in your microscope, analyze this. Practice, I find 10,000 personally. Again, this is subjective as the right multiplication factor for assessing. Again, remember, if Molly was just saying, Dr. Molly was saying 15,000 or 20,000, the same factor, platelet count of 16, you multiply by 15,000, your platelet count will become 2,40,000. If you multiply by 10,000, your platelet count will become 1,60,000. Imagine the difference in platelet count and subjectivity that comes because of a peripheral smear check. So for all the students out there, I'll repeat, if in 10 fields, you counted a total of 45 platelets, your average platelet count per field would have been 4.5. And this is talking about under the oil power at 100x objective. So your approximate platelet estimate, I have written your platelet count estimate only, would have been 4.5 to 10,000, which is 45,000. When I had very low platelet counts, I counted 20 fields and I got a total of 40 platelet fields. So 40 divided by 20, my average platelet count per field is 2. So the multiplication factor of 10,000 will be 20,000. Now, if your counter gave you a count of 16 or 18,000 or 22,000, will you change it? What if your counter gave you a count of 28,000? It is very challenging. Okay. You see different areas, different fields, and you might get different platelet counts. So again, it's an estimate. If there are clumps, there is a broad difference, that's a different angle. Your counter gave you a count of 20,000, you're seeing multiple clumps like that. You know that is not accurate. So Dr. Molly, can you do anything if you have clumps? What would you do? Would you give a higher count in your report? Or what would you do? If you see these two types of clumps in your smear and the count is 20,000.
So we will write a comment that platelet clumps are present.
Present. And then would you report that count? Would you not report the count?
So we will report that count.
You report that count. So we'll discuss that as we go ahead. Now, can you tell me this is a normal size platelet, medium, giant platelet? What according to you are these two platelets? Is this the size of a normal RBC? Almost close to the size. Can you see there's a smaller platelet over here? So what I wanted to bring to your light is this definition of what is called a giant platelet is very difficult. Just because you're seeing very small platelets and you see a little bigger platelet like this doesn't make. Generally, you would want a platelet which is the size of a small microcytic RBC at least, and that's typically what you want a giant platelet. And I'm keeping this platelet over here, a small RBC, almost the same size. This is a little larger activated lymphocyte with some few granules. A small lymphocyte, nuclei maybe slightly bigger than this giant platelet. Identifying what is true platelet and identifying what is artifact. These are all stain deposits. These are not platelets. So having a good stain is very important when you identify. Then obviously screening the tail. I did ask you that you need to review the platelet count in the area between the tail and the body. But not to forget, first thing when you're reviewing a peripheral smear, start at 4x or 10x. Make a habit to review the tail. Initially, you might want to start at 140 and go back. Once you have the confidence to start screening at 10x or 4x, especially for large clumps like these, you will, if you go in, you might miss them. So always screen at low power and look for clumps. Now, these are pools of clumps. These are typical of EDTA-induced pseudothrombocytopenia. Now, these are large giant pools. These are very different from small clumps. Sometimes I see students or reports saying small clumps in EDTA-induced pseudothrombocytopenia. This is not EDTA-induced pseudothrombocytopenia. Okay? These are different from these kind of clumps. And this is again, you might find fibrin strands, you might find capillary. If you see, there is degeneration of RBCs happening. This is coming from a stored sample, kept in the fridge, sent to us the next day. Actual platelet count previous day was fine. Then you had artifactual clumping, degeneration, and this also happens because the DNA denatures. There is stickiness of the WBCs and the platelets and cells start clumping. So this is problem of storage also. So we also know that running it fresh is better, and transportation storage can cause problems, which one should document. Okay, you need to document and look, and you will have clues. You will have irregularly acanthocytes, you will have changes in apoptosis in the WBCs, you might have clumps, which tells you is this a transported sample, is this a storage sample. Especially in private lab practice, peripheral lab practices, where you're receiving samples from outside, you will face the challenge. So a little bit of theory again. We move from the Newbar chamber at one end, manual. We have the flow. Flow is not present. It's not something which you do every day to count a platelet. So we move to automated CBC analyzers. Typically, most commonly, two principles are used. Most common being impedance principle. And the second commonly used now is the optical principle. Why are counters better and more reliable? So a well-maintained counter with good quality reagents, running controls, and using instrument-specific reagents is invariably far more reliable than the platelet smear count, unless it gives flags and says, or there are clumps. Okay, why? It counts far more cells than the human eye, is more reproducible, and typically it has higher CV of, improved CV of less than 5%. The CV may change when you have thrombocytopenic samples. So more the platelet count, lower the CV, lower the platelet count, higher the CV. This is typical for most counts. Because if you have less number of cells or particles to count, there is more variation, which is nothing but CV. If you have more number of particles to count, your higher count sample, you do a better, lesser variation, so a better CV. So impedance principle, you will learn more this in the principles of cell counters in the talk coming ahead. But it's based on the Coulter or resistant detection method. There is a pulse, which we call as the impedance signal. I will not go into this. And we only know the impedance principle or the impedance signal is directly proportional to the volume of the cell. And every cell or particle which passes through the impedance current is measured. multiple cells are measured, and we form what is called as a histogram. Okay. As we discussed in my previous talk on CBC histogram, and I'm going to repeat a little bit, the RBC and platelet histograms are actually one common histogram. Okay, and I'm going to dwell on this a little bit because this is very important to interpret histograms. The histogram looks different, the colors are different in different analyzers. So I'll show you 3-4 different histograms today, different analyzers. But bear in mind the principle. The leftmost point generally is called the fixed threshold. This is the lowermost threshold for platelets, generally at 2 femtoliters. Anything below this is debris or noise coming from the electronic machine. This third blue line, first, second, third, second moves. The third is the moving threshold. Second, you may not find in some analyzers, will vary. So you can ignore this for the moment. This particular threshold is called the moving threshold. In most analyzers, it moves between 20 to 30. It tries to identify the trough or the lower area between the platelet peak and the RBC peak. In a histogram, I'll repeat, what is the, if somebody can tell me from amongst the students here, what do we measure on the x-axis over here? Dr. Arpita, can you tell me what is measured on the x-axis on a histogram?
The volume.
Okay. And Dr. Mayuk, can you tell me what is measured on the y-axis of the histogram?
So this is percentage.
Anyone else? It's not the percentage. Anyone can tell me what is measured?
The number of cells of that similar volume.
So histogram is always a single parameter evaluation. On any histogram in the world, the left side will always be count. Okay. And the bottom is the parameter which you are measuring. So here, when we are measuring the particles, we are measuring, as rightly suggested, is the cell volume, where we measure it in femtoliters. So platelets are small in number in lakhs. RBCs are in million. So the peak of RBCs is higher than the peak of platelet. The peak is so high that the machine gives you 2 graphs. It shows you the RBC graph separately and the platelet graph separately, so that you can actually look at the platelet graph very carefully and look at variation in the graph. RBCs we know are bigger than platelets. Machine does not know this. Machine counts them as particles, platelets or RBCs. It is we have told the machine bigger cells are RBCs, smaller cells are platelets. Then it identifies a platelet curve and it says, okay, this is where the break is coming. It seems to the left is one population. Let me put this moving threshold over here and divide this into the left side as platelet and the right side as RBCs. This is what we are going to learn today, mainly in all my presentations. Typically, platelets have a size of 8 to 12 femtoliters and are counted between 2 to 30. So most are below this 12. And I'll come to why this middle line of 12 is important. This is based on this 12 value. Typically, erythroids, we know, are 80 to 100 with an MCV of 90. So this is the curve of 90. And the macrocytes will come here and micros will come there. We'll not go there today. So people who are used to Sysmex machines, for example, this is one of the instruments. This is the green line. Can you see here is the 2 femtoliter threshold. This green line on the right hand side is that moving threshold between 20 to 30. This is the normal platelet curve where it starts from the baseline on the left, ends at the baseline on the right. This is a slightly abnormal platelet curve, starts on the baseline, does not end on the baseline. This is a case of giant platelets, and we'll discuss this as we go. This is from a Beckman Coulter machine, the older model of Beckman, the LH750. This is the RBC histogram. This is the platelet. Here it is shown you separately, but it is actually a joint histogram. But if you see the size over here, it starts from somewhere around 30 on the left, which is not shown here, but then moves to the 50 to 300 area. Okay, different instrument, different slight values. If you go to the platelet, see where it is starting from 2, moving up to 30. This 20 to 30 is where there is a moving threshold. Then WBC as of now will leave. The focus is going to be today on the platelet histogram. Okay. Now in the Beckman, we have also what we call as a curve correction. There are 2 curves, and we'll discuss this as we go along. The green one and the black one. Now this is from a third analyzer. Okay, this is slides courtesy my colleague Dr. Neha. Okay, this is just to repeat the importance of the cutoffs on the histogram. And today the focus is purely on the platelet. So we are going to focus on the lower platelet cutoff, which is 2 femtoliters, the higher or the moving threshold, which is between 20 to 30. Below 2 is dust and EDTA particles or debris or noise. Above 20 or above 30 will be either big particles coming from left area, means big platelets, or small particles coming from right area, means small RBCs or small WBC fragments. Okay, this is what we'll see as we go ahead. So a normal platelet graph will start at the baseline around 2 femtoliters, go up, come down, and between 20 to 30 somewhere it will end at the baseline. If you see, as I told you, most platelets are measured between 2 to 12. Some companies put an additional threshold called as a 12 femtoliter threshold, and most platelets curves are left skewed, left to the 12 femtoliter threshold. This is normal for platelets. So you may have normal small size platelets. Few platelets are slightly bigger in size, and they are smaller in number, and then they go down and the platelet curve ends. So some machines may call it LD, that is lower discriminator. They may call it PL, which will be platelet low discriminator. Some machine may call this as upper discriminator or platelet UPU, platelet upper. Now remember the PU is the RL. So platelet upper discriminator is the RBC lower discriminator. Okay, because the curve is the same. So if you keep these terminologies, and your instrument may have your instrument specific name or terminology, it doesn't matter as long as you understand the concept of a fixed threshold led to a moving threshold between 20 and 30. So with this knowledge which I have shared, we go to the next set of questions. Who is the next student will be answering this? Great. So Navadi, Dr. Navadi, you will have to tell me in this histogram, what do you see and what do you think are the causes?
Here the lower discriminator is not starting from the baseline.
Correct.
So there is a elevation of lower discriminator. So it
Correct.
exceeds the percent height of 10 by 10%. So there is a lower discriminator flagging. So
Correct.
the causes would be small cell fragments, EDTA particles, and bacterial contamination, and high blank value. Also noise can cause lower discriminator elevation.
Excellent. So when you said noise, what do you mean by noise, if I can ask?
The vibration, the noise where the machine is
The
placed.
theoretical word uses electronic noise. You are correct. One way is vibrations. One thing is electronic signals. If there are disturbed electronic signals coming from the background, remember whatever impedance is measured by the electronics within the instrument. So if there is background noise or background signal coming within the instrument, or some problems with the electronics due to dust, due to water, due to humidity in a poorly maintained instrument, this is a problem which you will get. As you rightly said, bacterial contamination. Now, why do you think bacterial contamination will come into the reagents? Where do they come from? Any idea? Your answer is perfect, but I'm also sharing with you where these challenges come from and why they happen. So many times when we are changing the sheath fluid, we are not careful. We remove the aspirator or the tube from one tank, keep it outside. It's not clean. We keep it on the desk. We then load it into a newer sheath fluid, and you have contaminated that tubings. So when you're removing tubing from the old sheath fluid to a new sheath fluid, be very careful. Okay, follow instruction guidelines of the manufacturer. Problems happen when people wanting to reduce the cost of the CBC, use cheap reagents. They use fake reagents. They don't buy from the company. They use water. They use self-made reagents. They are full with bacterial contamination, and this is where you start facing these problems. So you may have the top line instrument, but if your reagents are not good, not well maintained, you might see these problems. So we go to the next doctor who's going to answer the question for the UD flag. Who is the one who's assigned this question?
It's me, sir.
Please explain the flag and the causes.
So here the distribution curve intersects the upper discriminator line at the highest point, that is up more than 40%.
Yes.
And the most probable causes are the platelet comes. It is because of EDTA incapability and clot, and giant platelets and microspirocytes. Sir.
So anything other than microspirocytes? So micro RBCs or microcytic RBCs would be the right answer.
Okay, sir.
Yes, spirocytes will not be there. So as I said, the machine does not know whether it is platelet or RBC. Machine only knows size. So when you are seeing variation over here in this area, it is either a bigger particle from platelet, which means either giant platelet or platelet clump, one of the two, or smaller particles from the right side, which is the RBC side. So smaller RBC can be microcytic RBC. It can be RBC fragments. So severe microcytosis, less than 60 MCV, please carefully look at your smears. Every patient with severe microcytosis, less than MCV of 60, please go back to your smears and see, and the graph, do you have the RBCs interfering with your platelet curve? Okay. And this number, while saying discriminator at 10%, 40%, remember this is only for this particular instrument and algorithm for this instrument. It will be different for your instrument. It may not even be known. It's okay. You can see the graph. The gray is the reference line, which is normal, and the red line is the abnormal. Now, this is an unusual, rare presentation. Next person who's going to be assigned this question. Can you explain what are you seeing and what could be the potential cause?
In this graph, we are seeing multiple peaks in the graph.
Correct.
Sir, it can be due to anisocytosis in the platelet, where there is a lot of variation in the size of the platelet. In cases of platelet transfusion, sir, or when there is aggregation of platelets present.
Aggregate.
Sir, in those. Yes.
So you are perfectly right that there are two populations of platelets. One which is appearing slightly normal in size because they are to the left of the 12. Okay, so they are normal. This is the normal left skewed, and there's a population of slightly larger platelets. Now, are these recovering from a chemotherapy, recovering from a transplant? Is there been a platelet transfusion? Patients' own giant platelets and normal transfused platelets, or platelet clumps? Massive clumps are happening. Again, variation in the histogram with peaks, look on the peripheral smear, take the history. So this is broadly in a very pictographic way to tell you, you will face these challenges in practice, you have to identify. So the major challenge we identified in impedance is that machine does not know whether I am platelet or I am RBC. It only knows size of the particles. So giant platelets in this size and small RBCs on this side is what we call as an overlap area. Machine cannot identify. That's when came the advent of optical technology. This is on one instrument, but I'm going to go to any instrument which has optical has the same principle. There will be two parameters. Now we have moved from a histogram to a scattergram. So two axes. This is FSC, which is measuring forward scatter directly proportional to the size or volume of the cell. So the larger FSC cells over here are the RBCs. Smaller FSC cells are the platelets. So on axis, I can separate the normal RBCs and the normal platelets. Okay. Small RBCs compared to the normals will lie here. Now, where do the giant platelets lie? You will say they will also lie here. They will go up in the axis. But what happens? On the bottom x-axis, here the terminology is called as side fluorescence. They put a dye over here, a dye which binds to RNA within the platelets, these green colored cells, or the purple red color RBCs. RNA containing RBCs are nothing but reticulocytes. They are larger in size, they contain RNA. This is how retic count is done by the analyzer. RNA containing big platelets contain RNA because they are the so-called immature platelets. This is the area where immature platelet fraction or reticulated platelets are measured in most machines. So the giant platelets go in this direction. So what happens? Small RBCs do not contain RNA. Big platelets contain RNA. So platelets are pushed in this direction. Small RBCs are pushed in this direction. Another pictogram. The RBCs are on the bigger than the platelets. Okay, so they are higher in FSC on this axis. This is the fluorescent axis. Giant platelets have RNA. Larger reticulocytes RBCs have the RNA. So they get separated. So the problem of giant platelets and small RBCs gets sorted in the optical platelet count. Challenge, you have to use a dye. The dye comes at an expense and it is present in the higher end current day 5-part analyzers. You have to do it in the retic mode or the reticulocyte count mode where you put a dye and you can separate these two. But in some cases, it is very, very important. Again, this is an example where I had lot of microcytic RBCs. Can you see the right side of the curve had a lot of variations, whereas the platelet curve had minimal variations. This was the case of microcytic RBCs. In this region, can you identify all the small RBCs? Platelets were actually normal count. Here, in this case, there was giant platelets. You see a lot of giant platelets over here. Look at this area is empty, whereas in this case, there are a lot of giant platelets. So you could separate the giant platelets. This area, there is hardly any small RBCs. This is how optical platelet count helps separating impedance. There are certain conditions where optical is useful. In most conditions, impedance is good. In thrombocytopenic patients, especially when there is peripheral destruction like dengue, viral infections, where the marrow is producing, especially in giant platelets you're seeing on the smear, sometimes the optical, and I'll show you some cases where optical is better. Now, this is a case which I like to share, and we know from our country, especially in patients of East Indian origin. When I say East parts of India, means from the Bengal, Bihar, Northeast side origin. We know there is a genetic condition where the platelets are slightly larger in size normally, and they're slightly lower in number. We call it macro thrombocytopenia. This is a hereditary thing. For them, this is actually normal. This is one of those donors who had come to our hospital. She's East Indian origin, 31-year-old female, wanted to donate blood and found to be having platelets of 130, 1 lakh in an outside sample. And she's like, I am normal. You are labeling me a thrombocytopenic. So we ran her on the impedance optical mode. If you see the machine selected the optical count, it was 1,62. Here is the impedance count 1,34. See the histogram. It is saying I have giant platelets. My MCV is 89.8, normal. Hemoglobin normal. There is no microcytosis. The RBC curve is beautiful. So there is no reason for it to have microcytic RBCs. Platelets are low on impedance. The graph is showing giant platelets. Optical count was more accurate and the optical count was reported. This person could donate her blood. Okay, it becomes as important as that. Again, it doesn't matter that every person is going to donate. The importance is if you ran majority patients of East India, and you will find a difference between optical and impedance when they have this kind of condition. Take home message is not to remember two things. In giant platelets, optical platelets is useful. Conditions where the giant optical platelet count may be better than the impedance. Second, patients from certain parts of East parts of India may have this condition called as macro thrombocytopenia, but it's not true thrombocytopenia. But be careful. The moment you see somebody from Bengal, don't label them as normal or abnormal. Check the history. Patient may have 10 reports. They cannot have one report of 1,80,000, which was normal, and suddenly you start saying 1,25,000 is normal for you. But if throughout their history, they've always had the borderline count between 120 to 140, this could be considered, but the clinician is the best judge for this. But you can raise this point. Okay. Now we'll go to case studies. Quickly go through case studies. So who is the next student? And I'll read out the question. The machine gave a count of 1,05,000. You did a smear, and this is the photograph. You showed multiple small clumps like this. Please tell me what would you do? Who is the student assigned for this? Sindura, can you guide me? Who is the student?
Arpita, is it you? We are unable to hear you. Could you please unmute yourself?
I took the last question. This was not assigned to me.
Okay,
I'm
who's
sorry.
the next one?
I think it was for Dr. Vignesh.
Divya Sharma? Divya Sharma, we are unable to hear you. We can see you, but unable to hear you.
We can't hear you, Divya. So I'll. Should I go ahead? Anyone else would like to take this question? Divya, sorry, can't hear you.
Sir, I think the answer should be B, sir. Ask for a repeat sample and don't give any platelet value and mention the platelet clump, that there are clumps.
So this is a patient sent by a surgeon who wants to do urgent appendicular surgery. Platelet count is 1,05,000. Patient is waiting for that platelet count. Is it normal or abnormal? If you don't give report, he's going to tell you, give me some value. What are you going to do? He's calling the ICU at 8:30 from the OT at 8:30 in the night. Pathologist is not in the lab. What you have come, you have seen the smear also. So he says, tell me, is it adequate or not? Have you seen the smear? What is your answer?
I think in the it's E, none of the above, and we have the platelet count should be 105,000, and we can mention that there are platelet clumps.
Okay, so that's a good thought. So what I personally do in practice, and this is again, all these things I'm going to share with you is from personal experience. I would say it will be a mixture of both the answers, and you're right that I would say the machine has reported a count of 1,05,000, and 99.99% once you see clumps, the count of the machine is the lower count. The actual count will be higher than that. So you can always mention the platelet count is more than 1 lakh, but there are clumps and the actual count may be higher than the above reported count. For an accurate count, please send me a fresh sample. Now the surgeon will say, are you confident it is more than 1 lakh? I can do the surgery. For an appendicular surgery, I don't need more than 1 lakh. But if the same question was for a brain surgery, for some complicated surgery, he might want to see what is the answer. So clinical scenario becomes important. So we mentioned the clumps. We mentioned that because the machine count was more than 1.05, it seems to be more than 1 lakh and they are accurate. But remember, the scenario will change. So the next question was assigned to whom?
Sir, this question was assigned to me.
Yes. So the platelet count is 3.35 lakhs. You saw similar slide, same clumps. Does it matter now?
Yes, sir. If the instrument's platelet counter of the sample is within or above the normal range, a count may be given with an added comment noting that there is a presence of clump and suggesting that the actual count is likely higher than the reported count, sir.
So that's a very good thing to do. So in these scenarios, it is important. Some people might argue, how does it matter whether it is 3.3 lakhs or 3.5 lakhs or 3,70,000? But the importance is, what if this patient's platelet count yesterday was 6 lakhs and he's a case of essential thrombocytosis, and today you give 3.35 lakhs with pools of clumps. So you don't know, especially in private practice we face, a patient has gone to 2 labs, 3 labs, and you got the 4th lab is checking your platelets with. So whether it is normal count or low count, definitely say they're adequate on smear. They're also seen in clumps. Report your count and say the actual count may be more than the above reported count. So once you mention the clumps, it is very important. Now, next scenario, who is answering this? Platelet count by the analyzer is 35,000. You are seeing an occasional small clump. What do you do? Patient is due for surgery. This is very important. So what do you answer?
So this question was also assigned to me.
Yes.
So first, if the platelet count is less than the normal range, then
Yes.
first we verify which method is used for blood drawing, because that changes the value. So we test blood sample collected in, we ask for the blood sample in sodium citrate or heparin. We can ask for that repeat sample, sir.
So if you saw an occasional small clump, you still ask for a citrate and heparin. It may not help you unless you see pools of clumps. Please label EDTA-induced thrombocytopenia only for those patients. As a habit, you don't want to bleed a patient, and you're actually worrying. And I'll discuss that case again. Here, the importance is you're seeing 35,000. Understand the clinical importance of this platelet count. Okay, so you have to tell your clinician, this is 35,000 is the counter count, but I'm seeing clumps. I'm worried. If you see only an occasional small clump, you know it is reduced. But you start seeing multiple small clumps on the slide. Whether the clumps are 3, 4, or 5 or 10, the platelet count is significantly higher. Someone will say, please run optical count and tell me the count. It will not help. Someone will say, do manual platelet count, do Newbar chamber, do peripheral smear. Please do not adjust your count based on your smear. Simply state count by the counter is 35,000. Because of clumps, it is unreportable. The actual count may be higher. So I approach it 2 ways. If you really want to report the count, please put a big disclaimer of how you're reporting it. If there are multiple clumps, please do not give the count. Say too many clumps on the smear. Accurate count is not possible and need a fresh sample. Okay, now needing a fresh sample, whether you require a EDT or citrate, we'll discuss along the way when it is required in the next case or two. Now, this is the next question assigned to one of you. Can you tell me
I was assigned this question.
Yeah, please.
The platelet count on the smear will be 70,000, which is low. So, and additional findings, there are schistocytes present and in helmet cell forms, and a few polychromatic cells and teardrop cells. And so it will.
You've got this CBC peripheral smear in your lab. Machine gave you a count of around 65,000. You saw the peripheral smear. You counted an average of 7 platelets per field, like you counted your 1, 2, 3, 4, 5, 6, and 7. You multiplied by 10,000, you gave a count of 70,000.
Yes.
You mentioned the schistocytes, and I'm marking them as we speak. A lot of schistocytes. There were microspirocytes on this smear. There were NRBCs. There's a left shift. There were some polychromatic macrocytes. And this is what you found. Now, what is the impression and what is the advice will you give?
This can be microangiopathic hemolytic anemias like TTP, hemolytic uremic syndrome, or DIC.
Okay.
So we can do additional lab findings like bilirubin, LDH, and haptoglobin, and fibrin degradation products, PT, APTT count.
Great. So, Dr. Divya, you work in a large institute?
Yes, sir.
Now, normally, if a smear comes to you, by when will this report reach the patient and when will the report reach the doctor? So, there is one more thing you need to do in this scenario.
Sir, sorry, I can't hear you.
So, what I was saying is there is one more thing one pathologist should do in this scenario, and I'll go ahead and, for sake of time, please pick up the call and call the clinician, call the patient. This is a medical emergency. If they don't know what happens,
If it is,
yeah, go ahead.
sir, it could be the case of DIC.
Correct. So we need to find out the cause. We might need to do a DIC profile. So the idea is to discuss the case with the clinician. So while I'm not discussing the causes of MAHA or microangiopathic hemolytic anemia, this is important that we as pathologists pick up the phone, discuss with our colleagues on the other side and say, this is what we are finding. What are the clinical conditions? Let's get to the bottom of this and then go ahead. So the more you do this, the more confidence will your clinician develop. And your complaints, your lab gives wrong platelet counts will go away. So the way to reduce complaints, your lab gives wrong platelet count, is not by saying my lab is good and my lab is the best and I am the best. The way is to discuss an open communication channel with the clinicians. Discuss. The challenges will always be there from both sides. You have ICU samples, you have heparinized samples, you have platelet lumps, you have difficult collections, you have cancer patients who have difficult veins. So a pediatric collection, a finger prick collection, all this can cause platelet lumps. All this can cause difficult collection fibrin stents. And clinical conditions like this, where you saw the RBC morphology, can be a great help for the clinician. So the challenge is communicate. Okay. So this is a case study. This is again showing you from a Beckman-Coulter instrument that we are seeing an RBC histogram, a platelet, and a WBC. This was a normal histogram. And in this condition, the machine gave us a value of cellular interference, platelet clump flag. Now, somebody's been assigned this question, correct? Now, this is the question which has been assigned. So my question was, if you see this platelet histogram, it is completely normal, starting at the baseline, ending at the baseline, but machine still gave the platelet clump flag. Can you tell me why? Who is the assigned this question? Sorry, go ahead.
Yeah, I'm assigned, sir.
Yes, great.
So it could be due to nucleated red cells and malaria parasites. And
So
also,
you are talking about the ghost area peak, right?
Yeah. Yes, sir.
Great. So I highlight again, the platelet histogram was normal. There was an abnormality in the WBC histogram. Now we have jumped from identifying a platelet histogram and identifying an abnormality in WBC. Okay. So you tell me the causes and then we will discuss. Okay. So the answer to this is?
All of the above.
Excellent. Now my main question to you, this is an easy question. It was very obvious the answer is all of the above. But why, in this case, it was platelet clumps? It was actually there on the smear. But why are the platelet clumps coming into WBC area? In the histogram. See the size in a WBC.
The size would be here the platelet histogram ends in 20 femtoliters. So yes. The WBC histogram starts from 50. Correct. So the platelet clumps, which are very large, which comes between 20 and 50 femtoliters, can come in the ghost area.
So where are the RBCs over here? Same size as normal RBCs, right? Where did they go?
They lies in the WBC channel.
Excellent. So in the WBC chamber, when the WBCs are measured, the RBCs are lysed. So all the lysed RBCs disappear. The platelets are not lysed because the size difference between platelets and WBC is so high. They normally do not interfere in the WBC count. Only interfere when there are platelet clumps. The only RBCs that interfere is when they are not lysed. That means nucleated red blood cells. If there are giant gametocytes or parasites, they become the size of a lymphocyte, they may interfere. Hence, the answer to this was all of the above. So the importance was not while looking at the platelet histogram. Okay, here actually the platelet count was 294,000. Platelet histogram was normal. You would wonder, why am I looking at the smear? Machine was right, platelet clumps, it picked up because of the ghost area and the cellular interference. So subtle things in the histograms can give you a lot of information. So again, I'll highlight, this is a normal platelet histogram. This is a ghost area peak. And we picked up some giant platelets. Platelet clumps over here. This is a normal WBC histogram where the curve ends at the baseline. Nothing in this ghost area. Ghost area is supposed to be an empty area. Here, if you see the green line, there is a giant histogram curve. And in the Beckman-Coulter, the black line is what we call the curve correction. Based on the angle at which the green curve was going, the black line continues, completes the curve, does the curve correction, and gives the platelet count. So this is a technology which is very beautifully used by Coulter instruments, where they call this a curve fit technology to give an accurate count in conditions with giant platelets. Next study, 72-year-old male. The hemogram showed this. Is this question assigned to somebody? I'm sorry, I'm not aware. But this was just for discussion, not assigned. Great, no worries. So there was the CBC instrument showed this curve. In the previous Coulter instrument, I showed you every time the counter gives two curves, the green and the black. Here, if you see the black curve correction is absent. Okay, randomly the green curve ended at 20. The black curve didn't come. Machine did not know where should I start my smooth curve, where should I end it. It is confused. There are too many variations. There is no normal peak on the left. It's all helter-skelter. Okay. First thing you do, see your histogram. Okay, let me see the RBCs once. RBCs in this case, MCV was 97.6. Histogram looked okay. There were no microcytic RBCs interference. Always check that. Looks like a genuine platelet problem. Either giant platelets or what could be the other cause? Anyone else? What could be the cause? Clumps. This was the true case of EDTA-induced pseudothrombocytopenia. Now, here we will not report the 54,000 count. We will say large pools of platelet clumps seen. This is a case of, potentially a case of EDTA-induced pseudothrombocytopenia. On smear, platelets appear adequate, at least more than 1 lakh, because it is clinically relevant. Accurate platelet count cannot be done. This is the scenario or the clinical condition where you will do two things. Ask for a repeat sample where the sample is collected in EDTA, where the sample is collected in citrate. And third important thing, which many of us forget, is the last drop while collection, especially if there's a pathology technician there at phlebotomy, can make a direct smear without putting into EDTA and citrate. The reason for this is in many patients with EDTA-induced thrombocytopenia, in this case, citrate corrected the count. But in many patients, even in citrate, the clumping remains because the platelets are activated. There, a direct smear made at the time of collection with the last drop of blood from the syringe is one of the most useful things, because the clinician will say, please tell me a rough estimate at least. Can I go ahead with the procedure? Is it accurate? They want some number or some reference. As long as you are consistent in your reporting, you'll be able to give them a clinically valid result. So this is the true EDTA-induced pseudothrombocytopenia. Small clumps, fibrin strands, please do not ask every time for repeat question citrate. It all comes at a cost, and trust me, the cost is borne by the patient. And it's pretty expensive at times. So again, the message is evaluate your peripheral smear at low power, look for pools of platelet clumps. Now, for want of time, I'm going to go ahead with this case and just share the point which I would do in such a scenario. This is a known case of acute leukemia where you know patient has blast on the smear, high WBC, platelet count is 18,000. Now, the importance of reporting 18,000, what you do next? You definitely do a smear evaluation. Before that, one can look for microclots in the sample. Now, remember, microclots sometimes are difficult to see. If you are worried about clumps on the smear, if you doubt, you may, in a challenging case, transfer or pour the sample of one container to another plain tube, see if there are microclots. That's sometimes the only way one can look at it. Look for strands and platelet clumps on the slide. So a good smear evaluation. Peripheral smear estimate may be done. Remember, you need to count at least 20 to 40 fields at such low counts to give a good estimate. Most important, be aware of the clinical decision. Discuss the case with the physician. With routine, you will know that, okay, 20,000 is your transfusion threshold barrier. This is a very important. Know the CV of your instrument at this level. Run it more times. Same sample. See what variation you get. You run the same sample in your instrument in a leukemia patient. Your values may range from 16 to 22,000. Okay. Let your clinician know this is your range of estimate at such low counts. Develop their confidence, and they will develop confidence in your reporting. Now, this is another case. Just going to show you the case. No questions here, but I might ask based on the histogram over here. This patient had hemoglobin of 8.5, a very low WBC count, 250, was on chemotherapy. Okay, was having anemia on chemotherapy, very low counts. Machine reported a platelet count of 1,39,000. Two things: we made a smear to look for clumps. There was an average of only 1 to 2 platelets per high power field, and this is the histogram. Can you tell me what potentially is the problem in the histogram? Is this a correct histogram, wrong histogram? What could we be facing? Anyone has any views on what could be the reason of this? Or can I do something in this scenario to give an accurate count? Do I have any other methodology to do? Smear I have done, it is 1 to 2. Machine is saying 1,39,000 on the impedance count. This is the histogram. So we actually ran the optical.
Scatter grounds.
So we ran the optical of the fluorescence plated thing. Machine gave a count of 10,000 now. And we are wondering, now this matches to our peripheral smear view of 1 to 2 platelets. Why are we seeing? So when you look at this histogram, there is, can you see this lower part of the RBC histogram? It's not really ending at the baseline smoothly. There is a hump over here. And this is continuing from this hump over here. The worry is, are there some microcytic RBCs? Are these fragments? MCT does not look so bad. So I was worried there are some RBC fragments or microcytic RBCs over here. For some reason, I thought, why not spin the EDTA sample? Normally, we never spin an EDTA sample. We always spin serum samples. We asked here, this sample was completely hemolyzed. There were RBC fragments over here, which was causing artifactually, post-chemotherapy, cancer patient, difficult range, difficult collection, unfortunately led to a hemolyzed sample. We asked for a repeat sample. We ran it both in the optical and impedance mode. The impedance mode now gave us a result of 11,000, which was matching. So again, the importance over here is not the hemolysis. This is extremely rare. You may not even see it in practice. I haven't seen more than 2 cases in the last 10 years. The importance is mismatch between the histogram, platelet count, and your peripheral smear. If you see a mismatch, please look into it. If available, an optical fluorescence count may be useful. A repeat evaluation is often helpful for the clinical perspective. Now, this is the question which I think I've given to one of y'all or 2 of y'all. Now, case scenario 1, who is going to answer this question?
It's me, sir.
Great. So in this first run, same sample, you got a platelet count of 2 lakhs. You ran it again, you got 1,92,000. You run it 2 times for some reason. Can you release either of the counts? Is this acceptable in your instrument?
Yes, sir, it is acceptable.
Acceptable. Okay. At what level will you say it is not acceptable? What
When
value?
when the coefficient of variation exceeds more than 5, sir.
So how do you decide 5? Why not 6%? Why not 8%? Why not 10%? How did you decide 5? Okay. So who is going to answer?
Sir, there is
So here, your answer
Sir,
is
there is
right because the
diurnal
difference is only 4%. Yeah, sorry, go ahead.
sir, there is diurnal variation of 4%.
Okay. So you're giving me the physiological cause of variation. I agree that is possible. That first platelet was run in the morning and second was run in the evening, and you got a variation, and the difference is 8,000. In percentage difference, the difference is only 4%. It is acceptable. My question was, if the difference was 8%, would you accept it? If the difference was 12%, would you accept it? And why not? So how do you decide this percentage acceptance criteria? So there are 2 ways one defines it. Sorry?
It's based on precision.
Based on precision? How do you... So, in your lab, you would be running controls, low level, normal level, high level controls, and you do your daily QC based on your QC charts. On your monthly review, you know that for this normal level control, my QC is 3%, or that is one way, or the cutoff is 5%, or the clinically relevant cutoff. At 2 lakhs, even if you give 190 and 210 platelet, it doesn't matter. It's not clinically relevant to the clinician. 5% is okay. Anything more than 10% is definitely significant. Why is the machine showing variation? Generally, good machines at this level do not show that much variation. If it is the same sample being run twice. If it is morning, evening, 2 samples, as you said, diurnal variation is possible. Now, case scenario 2, first run 24,000, second run 16,000. Difference is only 8,000. So the absolute difference in both scenarios is the same, 8,000. But what is the percentage difference over here?
Sir, in this condition, the percentage of difference is around 33%. So that is a lot of difference and will change the clinical course, and the condition of the patient depends on the.
So the idea,
count
as you rightly said, this is a very clinically relevant question, because we are at the borderline of the transfusion threshold of 20,000 and the clinician is banking upon you. Unfortunately, this happens in practice. Okay, patients on chemotherapy where their marrow is suppressed and they have small platelets, you generally won't see such a difference. A patient of dengue where there is peripheral destruction, there are numerous giant platelets. Even in the best counter morning evening sample, you might see, sometimes even in the same sample, you might see variation. This typically happens on impedance counts in dengue patients. If you did an optical count for such patients with giant platelets, the difference may not be much. Again, the idea to tell you is absolute difference of 8,000 was same on both levels, but the percentage difference was different and it has a different clinical impact. So remember, you are a pathologist, but you did your MBBS and you are a physician first. Never forget that. Put yourself in the physician's shoes. Think what action would you take based on your report, and you start reporting in a much better way. I'll end up with the last case over here. Again, just to highlight, This was a 7-year-old child, hemoglobin of 9, a platelet count of 17,000. Okay, there were a lot of additional parameters which we saw here. A retic count was very high. There was RPI, and we saw the smear. And we have discussed this case, but I'm just highlighting very low platelet. There were schistocytes, there were microspherocytes in this case. And remember, like schistocytes and fragments, we have a parameter called as automated schistocyte count. Parameter is called as fragmented retic count. The idea today is not to discuss this parameter, but remember, schistocytes, when they come, they act as fragments. They can lead to problem. You will say they can increase the platelet count. It can, but generally they are associated with thrombocytopenia. So that problem doesn't exist generally. However, you may do a fluorescent or an optical platelet in such scenarios. You may do an impedance and get an accurate platelet count. Invariably, thrombocytopenia is often associated with this condition where you have schistocytes. Sometimes due to storage artifacts, you see irregularly contracted RBCs. Severe iron deficiencies, you see irregularly contracted RBCs. And you may have normal platelet count. Please do not jump and call them schistocytes. And spherocytes may be seen in transfusion. And if the platelet count is normal, do not label that as MAHA or microangiopathic hemolytic anemia. So clinical scenario history is very important. With this is, this is my last case for the day, and very interesting one. And somebody will have to help me out in this case. WBC count 23,320. Hemoglobin 8.7. MCV 54.8, MCH 15.6, MCHC 28.5. This case came to us for a review in our lab, and we do a test called CBC Advanced, where we run CBC, peripheral smear, and a retic count. We had 2 platelet count given by the analyzer: 26,80,000 and 1,17,000. This is the RBC and platelet histogram. Which do you think is the correct count? Which do you think is the correct count, and why? Any clues from the information given to you over here?
Sir, 1,17,000, because there is microcytic picture as is evident by the MCV, and that is been incorrectly counted by the impedance.
Super.
Machine.
So you have passed me in my exam. I have succeeded in teaching you the importance of histogram. Thank you. So the importance over here is the RBC curve over here. If you see, this is the same which I told you was the PL, or the platelet lower, the PU, which is the platelet upper reference line, or the RL. RBC lower reference line, the RBC histogram is crossing it and going into the axis. A significant proportion of RBCs are going into the axis of platelets. If you saw, the RBC count was 5 million. This patient potentially has thaltrate with iron deficiency anemia based on the indices, has 5.5 million RBCs. Even if 2 million RBCs, 2.5 million, half of them, if you see from the peak, almost half of them have entered into the platelet area. And that half is 2.5 million on 25 lakhs or 26 lakh platelets, which has been counted by the impedance count. The optical count gave us 1,17,000. We obviously saw the peripheral smear in this scenario. Not the best light, but there was dimorphic population, there was severe microcytosis, there was transportation artifacts, irregular contract RBCs. Platelets average count was somewhere between around 10 to 11. There were a few giant platelets. In this field, we are not seeing so many, but this is a picture, so only half the field is being shown from the photograph from a mobile phone. So again, we did not see 26 lakh platelets. We saw microcytosis, and I showed you an example of how microcytosis can lead to false platelet count. So here, the importance is just blindly do not rely on the platelet count. This is an extreme example. You might get a platelet count of 3 lakhs. You may not have optical count in your lab. You may not even have the technology available. But you will have the histogram, and it will tell you, I am wrong histogram. Don't miss the histogram. Okay? With that, I would like to thank my whole team who supported me for this talk. And I would like to thank the students for participating. And we'll hand over to Dr. Mahapatra and then the students for further discussion and questions. Thank you so much.
Thank you, Dr. Kunal, for explaining beautifully how to approach a patient with low platelet count. I think everybody must have learned a lot from this lecture. So I think a lot of worry may be there. I think students can ask and we can discuss this one by one.
Thank you, sir.
Thank you very much, sir. So there are a couple of questions in the chat box. One question is regarding the platelet count estimation by peripheral smear. There's a comment if we can make a fresh finger prick smear and do the estimate on that smear. Would you advise that to avoid the EDTA-induced total thrombocytopenia?
So one of the causes of platelet aggregation is a finger prick smear also, because you are then doing a capillary collection. In a capillary collection, there is potential chance of causing clumping. So while you want to get a count from an EDTA-induced pseudothrombocytopenia, I would not say that is the right option. It is happening because of the exposure to EDTA or sometimes rarely to citrate or an anticoagulant. So best is from the direct smear from the syringe, the last drop or the first drop, make a direct smear. Finger prick smears are used, especially in cancer patients, especially in pediatric populations. With experience, you can do that. If you get a good platelet count, you're fine. But if you get clumps, that still remains a challenge with capillary collection. So I don't think that's the best option in such a scenario.
Yes, sir. Precisely for that reason, we do direct finger prick smears when we do hemostatic screen to look for platelet aggregation, and lack of aggregation is typically directs us to do platelet function analysis.
Correct.
Another question was regarding dilution factor correction for platelet count on citrated blood sample. Would you recommend doing that, or would you use dried citrated too?
So I think all parameters measured in citrate, because we use a 1:9 ratio over there. So there will be a multiplication factor which we'll use, whether it is RBC, whether it is platelet, whether it is WBC. And this is very useful because when you compare your EDTA and your citrate RBC count, WBC count, they may not always match. Platelet, obviously, you had clumping. By doing that multiplication factor and correction, I think it is a must, and one should do that correction before you report that.
Yes, sir. We generally in our lab we make homemade dried citrated tubes. If we request for citrated blood for platelet count, we supply them ourselves. But sometimes when we receive citrated blood from outside for platelet count, we do a dilution factor correction by 1.1 multiplied by 1.1.
Perfect. And that's the perfect factor. 1.1 is the multiplication factor for all your numbers in the CBC report.
Yes, sir. There are still some doubts regarding thrombocytopenia by the low platelet count given by automated cell counter with the smear showing small occasional clumps, which you discussed as part of the case study. So I think there are several people who are not yet clear about that. Could you please clarify on that?
Okay. So I will re-clarify. I will give you 3 scenarios. I showed you the pools of platelet clumps in EDTA induced thrombocytopenia. Suppose I think none of us have a doubt that that is adequate platelets more than 1 lakh on smear. You cannot give the machine reported count of 20,000, 50,000, whatever you got. You put a dash there, you say see your comment, or you put it in a platelet. Accurate count cannot be done. Pools of clumps, platelets are adequate on smear. Putting that adequate on smear is very important for the patient and the clinician. Second question is, whenever there are clumps and there are multiple small or large clumps, no method of platelet counting will be accurate on that sample. Neither new bars, neither manual, neither flow, neither optical, neither IPF, neither anything. Okay, clumps, platelets cannot be counted accurately. That is one point to be remembered. However, in every sample, when you get clumps, the idea is a 1,35,000 with clumps. Clinician will say, I don't need to repeat the sample. So don't say repeat sample, send EDTA, send citrate, send peripheral smear, and don't report a count. You say machine count 1,35,000, occasional small clump seen, platelet count may be more than adequate, more than the above reported count. Clinician knows it is more than 1,35,000. Clinically, he will take a call whether he wants to repeat the sample, he or she wants to repeat the sample or not. Now, scenario, the most difficult comes when it is 20,000, 30,000, and you are seeing multiple clumps. Unfortunately, at this time, you have no answer. You say multiple clumps seen, I cannot give accurate platelet count. I will require a fresh sample. Ask an experienced person, especially in ICU samples, ask whether it is a difficult collection, whether it is a child, whether it is a cancer patient, whether there is a cannulated sample you can collect. What are the challenges the ICU is facing, especially in IPD patients, you face this challenge. Because every time you repeat, they bill the patient, they charge the patient, there's a venipuncture is happening again. It's challenging. But then there is no choice. When you get a 30,000 count or a 40,000 count, on the smear, there is a very occasional clump of 3 or 4 platelets, no fibrin strands. Check the history. Okay, this patient has been coming IPD or OPD every other day, always similar counts last few days. Okay, you might say there is an occasional small clump, maybe slightly higher, but overall platelets appear to be reduced. And history has been checked, patient has been having a thrombocytopenia. Now you check the history. Patient yesterday had 90,000, today has 30,000, occasional small clump. Now you are worried. Because now the question will come from the physician or from you, why this change? What has happened to the patient? Is there a clinical scenario? Has the patient developed a new fever? So again, now you have to discuss with the clinician or repeat a second count, which anyways the clinician will do at maybe in 12 hours time. So this is how I would approach different clinical scenarios when you have platelet clumps. I hope that answers most questions.
So there is a follow-up question.
So maybe Dr. Sindhura, maybe I would ask Dr. Mahapatra to chip in over here. Sir, is this the right approach from a clinician's perspective, or would you like to add something? Because this is a very common problem which you might also face.
Okay, so I think your answer is right, but depends upon the disease. For example, patient of immune thrombocytopenia, I am happy with platelet count of 30 to 40,000 if there is no bleeding. Okay, you should understand platelet count and the bleeding manifestations are not always directly proportional. Okay, especially in immune thrombocytopenias, because there are young platelets. Patient can tolerate a lot of low level of platelets clinically. Okay, so but patients with aplasia and MDS, when there is a defect in bone marrow suppressions, we need to target a platelet count for its normal to prevent bleeding manifestations. Or sometimes clinical points will help you out, like if a blisters in the mouth or sometimes wet purpura. Okay, wet purpura. Then even if it's 30,000, you say clinician will be a little bit worried to give a lot of more platelets on that. So it's always not a platelet count alone. It's always a clinical manifestation along with that.
Thank you, sir. So true. Shindra, go ahead, please.
Thank you, sir. Yeah, there was a follow-up question. I'm not sure if I understand this question correctly. They use the audience, they use the cutoff of 1 lakh platelet count for a smear review. And the example that you had shown, the count was 1.39 lakhs, which was above their lab cutoff. So the question is how to suspect such a scenario when the analyzer is giving a near normal count.
So one simple answer, the cutoff of 1 lakh is okay, because especially in big institutes, especially with oncology practice, many places the flag review rule is 1,39,000. But I would still suggest, even if the flag review rule by the count is 1 lakh, if the platelet histogram flagging is there, or if you see the abnormal histogram, that should be a second criteria for reviewing the smear. So your count may be 1,39,000 or 1,59,000, but the histogram was grossly abnormal, and all instruments will say platelet histogram flagging or abnormal platelet distribution or some name which the counter or the company uses. Once you get that abnormal histogram flagging below 1,50,000, I would suggest that should also become your secondary slide review criteria. So unless we form a habit of seeing the histograms, now the challenge will be these histograms are seen by the technician and that he or she is now making the slide. So we need to train our technologists. We need to share the same knowledge with them.
So now the question is on the allowable error. So if the level 1 QC, if the CV is more than 5%, would it be acceptable? Would you accept that? Are there any regulations to keep the allowable error to 3 or 4%?
I am assuming level 1 is low level, and typically a low level CV can be higher than that. Now there are two challenges when we are looking at QC sample, and again what sir was trying to highlight, understand the clinical perspective. So I'll answer it in two ways. The first answer, is it okay? It is actually okay for a low level platelet count control to have a CV of more than 5%. There are different clinical as well as CLSI guidelines which give cutoff levels for CVs for different parameters. The DESI textbook of hematology also gives some guidelines. They may not give it level 1, level 2, level 3 wise, but it does give. Enumerating is important. One practice which is very commonly done is people run platelets or any control. The moment they see slight variation in the control, even a warning of more than 2 SD, that value is deleted. And when you see the CVs are beautiful. It is 1% and 2%. They are never true because you're deleting that warning signal. So it is important for you, for the patient, for the clinician to accept a true CV. Obvious, if there was a clog in the machine, there was a major error, the sample did not control, don't take that count or control value. But minor variations in your day-to-day control, document it. So you know your variation of 7%, 8%, 9% is there. So your clinician knows it. Now the importance more than level 1 is to identify what is the mean platelet count at level 1 QC. Most commercial controls, as far as I am aware of, I have not seen a control which has a platelet count of less than 70,000. And if you ask Mahapatra sir, at that level, there is no problem. Doctor starts at 20 and 30,000. Do we have controls at that level? So what do? We never measure our variation at that level. That's why I said there are two types of samples you'll see at low level, as sir was saying. One is the immune type, ITP, who are very stable. Run those samples 10 times. See the CV in your machine. There will be a transplant patient recovering with small platelets. And there will be a patient of dengue with giant platelets, where impedance count every time you run will be 18, 25, 35, 20 on the same sample. Okay, you have to understand this variation. If you do study in your own lab, assess it, share it with your clinician, see their confidence level go up. They will know in this condition, this machine gives us a CV. And that is why knowing your machine, knowing how you use it, maintaining it becomes very important.
Sir, and even the linearity, when we check the linearity of the machine, it generally for less than 5,000 platelet count, even the manufacturers do not say that the linearity will be maintained less than 5,000. So that is another reason that we should run the patient samples clinically, where we know that there is thrombocytopenia to correct our CV. So this next question is for the Mahapatra sir. Sir, in case of dengue patients, how much drop in platelet count in 1 day is acceptable? Whether platelet count difference of more than 1,20,000 is acceptable, or should there be a root cause analysis for that?
So platelet count drop is also important to monitor, but always count is important and patient condition is important. As you know, in dengue, in third, fourth day, we usually see a drop in counts. Okay, so we always look for platelet count. If you see drop more than 10,000 up to 1.2 lakhs, this is definitely we should cautious and look for the clinical scenario when you look for any batches anywhere or not. But you don't expect any platelet count, any bleeding manifestation if less than 50,000 at least in acute onset. Okay, You are not worried, but you will keep a watch on that to look for any bleeding manifestation on that. Definitely look for again, repeat platelet count again, maybe one day, next day again, if there is a drop significant.
Thank you, sir. Sir, the next question is from, I have a question regarding the immune thrombocytopenia evaluation. As we know that the guidelines, ASH guidelines state that it's a diagnosis of exclusion, and while no specific test for ITP, there have been reports on doing antiplatelet antibody testing, especially the anti-glycoprotein antibody testing. What is your experience in terms of the lab tests and also the clinical relevance, sir? This is for both of you, sir.
For my side, I have practically zero experience of running antiplatelet antibodies. We get asked this test. I don't do it in our lab. I've not done it in my previous institute. I would leave it to sir and his experience on the same.
We don't do normally because there is a not linear correlation with the antibody and ITP. ITP can possible without antibodies. It's antibodies, okay. Okay, so the normally we don't monitor for that, but whenever there is some research interest, then we do monitor that. Otherwise, we don't do routinely antibody testing for all immune thrombocytopenia. Mostly it is a disease of exclusions. We should exclude clinically, then you know the clinical findings other than immune thrombocytopenia and isolated thrombocytopenias. Even patients other than elderly patients who don't do bone marrow also. Because the best way you can assess whether it's immune thrombocytopenia dealing with without any clinical manifestation other than isolated thrombocytopenia is the response to steroid or IVIG. Then it is most likely dealing with immune thrombocytopenia. Okay, but you are right. Sometimes we do antibody, but there is not a strong correlation with that. Normally, routine you don't.
Thank you, sir. So another question is on the immature platelet fraction. I know Kunal sir has studied it in detail. Sir, would you please comment on that and its role in the thrombocytopenia due to peripheral destruction? How would we use it?
So this popular has become, this parameter IPF, immature platelet parameter fraction, has become very popular to the extent that now it's being abused also at times and misused. So two things, immature platelet fraction is akin to reticulocyte count of RBC, similar because we are looking at giant platelets which have RNA content. So though they may not be really immature, they are reticulated platelets. Every machine which measures IPF has a different algorithm, different calculation, which means your IPF on your machine, you need to know your normal reference ranges, at least for that instrument. That is one. Even across systemic instruments, and I have used 3 of them, the reference ranges are different for all 3. So the clinical interpretation is different. 2 different companies, reference range is different. That's point 1. Point 2, in peripheral destruction, when there is thrombocytopenia and the marrow is being stimulated, if IPF is increasing, it is a good sign. It is an indirect evidence of immature platelets coming from the periphery or young platelets coming into the peripheral blood. However, if there is post-chemotherapy myelosuppression, aplastic anemia, if the platelet count is low and there is no IPF increase, it is very stable, it is low in the 1 to 2% range, it means the marrow is not responding enough, which indicates that there is lack of marrow response. Now, absolute numbers of IPF is very difficult because one, your platelet normal reference range ranges from 1.5 to 4 lakhs. In our machine, the reference range is 1 to 6 for IPF. So for a patient whose IPF moves from 1 to 5, that is a significant increase. But what if the patient's IPF was 4 and now it increases to 5? So how do you measure it? So that's the challenge. So second challenge, again, if there are clumps, IPF is not reliable. The platelet count itself is not reliable. IPF is of no use. Okay, we didn't discuss about MPV, about the other parameters, because with giant platelets, sometimes the curve where the MPV is measured, you saw all those giant platelets zigzag happening. The machine cannot put the correct area. It cannot measure the mean platelet volume. So it works out the MPV. So you go back to the peripheral smear, and often many people will say, can I see giant platelets on the smear and correlate with the IPF? Yeah, there is a correlation, but giant platelets counting on a smear is extremely subjective. Well, IPF has some objective value. So you can use to monitor it. There are articles published by us, by many various people now on utility of IPF. I would request you go and read. But the importance, 2 things, in clumps, they are not reliable. Below 10,000 platelet count, the absolute IPF number may be of not much value. You might get an IPF of 25%, 35%, 45%. Practically, at a platelet count of less than 10,000, they all mean the same. They only mean the marrow is responding. So that's the way. Use it judiciously with your settings, your references.
Thank you very much, sir. I think we are now at the end of all the questions in the chat box and my own questions. So thank you very much, sir.
Thank you.
It has been a very lively discussion, and I think sir has covered most of the problems that we routinely face in day-to-day practice. And thank you very much, Mahapatra sir, for giving clinical insights to us, because obviously platelet count, whatever we see in the machine has to be correlated clinically. And thank you all the students for actively participating and preparing well for the questions as well. and the audience for keeping the discussion alive. And I would like to remind you that the next lecture is on Wednesday, 7 p.m. instead of Tuesday. And the discussion will be on the 5-part and 3-part hematology cell analyzer. And the discussion will be taken by Dr. Sukesh Nair sir from CFC Vellore and Dr. Anil Handu sir from BLK Max Super Specialty Hospital, New Delhi. And the next slide seminar will be on the inflammatory lesions of the gastric mucosa by Dr. Anna Polimod of CMC Vellore. And thank you very much. And if there are any no further questions, I think we will end the session. I thank my